Also, if you can see, the chin is also retrograde. So just 5 more minutes. So when you see her smile, she's got a buccal corridor space which is quite narrow. And what I want you to see is that the canine is buccally placed and there's so much recession on the canine, right? You can see one canine is totally out of the arch and there is so much crowding on the lower anteriors as well. So now if you see just 6 to 7 months into treatment, the same canine has come in place very well and the gingival health is also improved. It's not worsened. So the whole buccally placed canine here was completely aligned into the arch. And you can see there is no lower incisor extraction also which was done in this case. The arch expanded so well and the crowding was alleviated. Once more you just see the arch form. The upper arch is so constricted, right? So the arch selection, the case selection is very important. You should have a constricted arches. So if you can see here, broad arches with so much of space to resolve the crowding. In this case, we got so much of expansion of 7 millimeters in the premolar and only 1 millimeter in the molar region. Moving on to the third case, if you can see how much of crowding the patient had in the upper, both the canines were buccally placed. You can see how much of wire deflection it produces. The lateral is here, the canine is here, the premolar is here. You cannot engage a normal night-eye archway, all the brackets will come off. Since it's a copper night-eye and such a flexible wire, you can see how much deflection the wire tolerates. So this case we resolved the crowding, but then lower incisors were very challenging. We had to end up extracting the lower incisors, and also we were losing torques. That is why we gave an anterior bite plane to extrude the molars and correct the D-bite in this case. Otherwise, usually most of the patients, the anterior bite plane is also not required. So if you can see here, we did extract one incisor, but upper arch we managed non-extraction and aligned both the canines which were out of the arch. And here is she is a BDS student, so she was very hesitant for extractions. You can see the amount of crowding which is present here. But the lateral was here, the canine was here, the retained deciduous, and there was crowding in the lower anterior as well. So the patient opted for ceramic self-ligation. The trade name is Damon Clear. So here if you see, the slot is also clear. What the patient will perceive is only the arch wire. So it's more aesthetic option compared to the conventional appliance. And this is one important tip I want to tell you. This is called a blue bite. I think most of us will be using it in our clinic. This is a big savior because the tight occlusion, whatever the patient has, if you can relieve it a bit, the masticatory force is going to reduce. The debonding will be less. You should not put in a chunk of blue bite so that the patient develops a TMD, not to that extent, just to the extent of 1 or 2 millimeters such that the occlusion is relieved. Also, this facilitates more expansion. Once you relieve that tight occlusion, the arches are free to expand. So this blue bite is a very useful adjunct, especially when you treat cases with expansion. So in this case, if you can see, we resolved all the crowding, but we had lot of challenges in this case. We did open up the contacts using abrasive proximal strips. So one other tip is, if the lower anterior crowding is not resolving at all for many months, this rotated incisors, just break the contact using proximal strips, not the aeroter. Just use those strips to break the contact and that will help to resolve the crowding much faster. So this is also a non-extraction case. We did not extract in both the arches and we managed it very well. Here is another case wherein you have so much of crowding in the lower anteriors. We did not extract, we just went ahead with same Damon protocol and we treated the patient very well without proximal stripping or extractions. Last case with so much of crowding in the upper and the lower anteriors. In all the cases, if you see, the second molars would have been bonded, blue bite for disocclusion, and all the teeth has to be included. Only in this case, we didn't include the lower anteriors because the canines were distally tipped. In those cases, we should not include the lower anteriors in the beginning. Otherwise it will proclaim severely. So once the canine aligns, then you can bond the anteriors and use it. So my take home message will be self-ligating appliance. My experience is more with Damon appliance. It's a bit expensive compared to the other self-ligating appliances, but it gives results and it works. So of course Nagarajan sir said about other companies, they are also equally good and they also give very good results. The appliance is only a tool. It is the orthodontist who is going to treat, plan is more important. So the first thing is case selection. You should select patients who have a flat face, okay, with an obtuse or average nasolabial angle with already competent lips. Basically, their face should be good and then or pleasing. Then you must have crowding in the upper or in the lower or both the arches with constricted V-shaped arch. That's a very important key point. And the patient should tolerate some amount of proclination even it happens. You should not create a flat face with non-extraction. You should not create a protrusive face. That also you should keep in mind. And adhering to the principles of the appliance. Change of arch wires only once in, you review the patient once in 8 weeks, and change of wires only when that wire has completed the work. So you move on from round wire to a rectangular wire, each wire at least for 3 months, and second molar is in the setup, blue white, and there is no need to use any other auxiliaries along with this appliance. Okay, so this is a very important useful adjunct in our clinical practice. But I should also tell you the downside of this. If you want to put in an e-chain, all of you must have seen your orthodontist or you will be using e-chains. In a conventional appliance, it's so easy to put it around the tie beams. For this, there is so much time and effort required to put in the e-chain and to take out the e-chain. Because the design of the bracket is such that the e-chain will slip. So what happens now, they are asking us to take out the wire, put the e-chain first and then put the wire on top of it. So in the next visit when you want to change the e-chain, you will have to take out the wire and then replace the e-chain. First thing. Second thing is, whenever you want to use hooks, it becomes very cumbersome. Rotation corrections is not easy. So these are all the downsides, but comparing both, the benefits outweigh the disadvantages. So you can introduce more of this appliance in your practice. Patient can also get a better appliance and also the treatment outcome. Thank you. So I would like to thank the IDA Tiruvallur branch.